Today our CME is on a very important topic, and I'm really grateful to Dr. Imran Hassan, who has come from GMC. Dr. Imran is a family physician, is consultant family physician, currently working in GMC. And thank you for coming here on invitation. The topic is very important indeed for all of us. So before we proceed, I would like to proceed with the verses of Holy Quran. Qari Sahab to come here and recite holy verses before we start.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. يا أيها الذين آمنوا استعينوا بالصبر والصلاة إن الله مع الصابرين. ولا تقولوا لمن يقتل في سبيل الله أموات بل أحياء ولكن لا تشعرون. صدق الله العظيم.
Jazakallah. Now I request Dr. Imran to please come and proceed.
Assalamu alaikum everyone, and thank you Dr. Shan for the introduction. So today's topic is on enteric fever, and it's a very common, excuse me one second. Sorry about that. So it's a very common disease condition encountered in the community, and I'm sure all of us are exposed to it and manage it very frequently. So I'm thankful again to Dr. Umar Farooq as well for inviting me here to deliver this CME. And without further ado, Bismillah, let's start. So briefly, the objectives of our session today would be just to go briefly over the clinical epidemiology and presentation that this disease comes with, because this is a disease that has a very, disguising kind of a personality. It comes in very different kind of presentations. And also the diagnostic approach, we'd like to familiarize ourselves with it, and the current management recommendations regarding this disease. So basically, as we all know, it's a febrile illness caused by Salmonella typhi predominantly, and Salmonella parasityphi in some cases. And children are more commonly affected and also have a more severe presentation with this disease. Low socioeconomic groups are another area of the population that are more affected, because there is factors for this disease such as poor sanitation, poor hand hygiene, poor quality of drinking water, etc. These go along with these groups. PPI use, interestingly, has also been found in systemic reviews to be associated with susceptibility. The reason being that it decreases the acid secretion, which is in a way it's protective against microorganisms. So prolonged or unnecessary PPI use is something that would be avoided to prevent this. So the scope of the problem is huge. 14 million infections annually, and 1,36,000 deaths annually. That's a huge number, and South Asia accounts for a large portion of this morbidity and mortality. So in Pakistan, about 48.5% of the infections are MDR, which is multi-drug resistant organisms, and 64% are fluoroquinolone resistant as well. So this was the situation before 2016, and in 2016, as we all know, the extended drug resistant strain of Salmonella typhi was found in Karachi, Sindh, and now it's quite a problem, because that strain was not only resistant to fluoroquinolones as well as the first line agents such as chloramphenicol and sulfamethoxazole, but also resistant to agents such as ceftriaxone, and was only showing some susceptibility to azithromycin and carbapenems. Right, so if you look at this map of antimicrobial resistance to typhoid, you can see that red spot right there, that is Pakistan, and that is an area. So you can see Pakistan right here, and if you look here, it says variable MDR plus fluorochemical resistance plus ceftriaxone zone resistance. So that is the highest level, that is XDR typhoid, which is found in Pakistan. So because of this, a lot of travel advisories were also given by various organizations such as the CDC and WHO for people traveling to and from Pakistan. Okay, so in terms of pathogenesis, the incubation period is known to be about 1 to 2 weeks, but in extremes of cases it can range up to 60 days. Fecal-oral transmission is the only route, and I'm sure we're all familiar with this. The organism enters into the intestines and then enters the submucosa of the gut, and from there the lymphoid tissues spreads to the reticular endothelial system, leads to hepatosplenomegaly and replication there, and then secondary dissemination to the rest of the organs. And this is important to know because this kind of helps us think about how the symptoms of this disease evolve. So we are all familiar with this classic presentation, the week-wise approach, week 1, week 2, week 3. And so in week 1, we would expect a stepwise rising fever with chills and relative bradycardia. Now, at this step, I think a lot of the cases that are generally labeled as typhoid, I think it's very important to discuss with the patients as well whether they're actually having a fever, because feeling febrile and being febrile are two different things. It means someone could, let's say, be hyperthyroid, for example, and they could be having a fever, or they could just be feeling fatigued and they might feel that, Dr. Sahab, bukhar महसूस होता है, कमज़ोर रहता हूँ, बुखार महसूस होता है. It's always good to have a documented fever in the case of typhoid, because typhoid is not a disease that gives you a mild fever. It gives you a definite rising trend, a high-grade fever, a persistent fever. So that is like a prominent feature of the disease itself. And in children, they might only present with fever and no signs at all. So paying attention to the fever is worthwhile in establishing the diagnosis. Relative bradycardia is a finding that we see in the first week as well, wherein the heart rate actually decreases while the patient is febrile, which is the opposite of the physiology. In physiological cases, the heart rate is supposed to increase with increase in temperature. But if that's reversed, that again is a clue towards enteric fever. We're moving on to week 2, we start getting those abdominal symptoms, abdominal pain. Some patients might have diarrhea, some might have constipation as well with this. And the abdominal pain is generally quite diffuse, and but it might mimic appendicitis in some cases as well, might localize to the right iliac fossa. Rose spots are a classic finding, but nowadays systemic reviews report that this is something that's very less seen very uncommonly. So it might be that the disease presentation is changing in that aspect. In week 3, we see that classic hepatosplenomegaly, because now the organism has gone and spread to the reticular endothelial system, is replicating there, and now is starting to disseminate widely across the body, leading to these other presentations, let's say septic shock, intestinal perforation. So week 3 generally is quite late in the classic disease history of typhoid. GI symptoms are prominent in most cases, except in children they might not be there. You might just have a fever. So diarrhea and constipation and abdominal pain. There are other symptoms that also are associated with this disease, such as headache. In about 50 to 90% of people you will find a headache, arthralgias, myalgias. And a cough is sometimes unexpected with typhoid, but it's something to look out for, especially in children, where it can actually develop into full-blown pneumonia along with this. And it's a dry, hacking kind of cough, not a productive cough generally. Typhoid encephalopathy, again, in late cases you expect to see that. So the abdomen is generally tender, but it's diffusely tender, but you would expect some hepatosplenomegaly along with this. And complications we're all familiar with, so GI bleed can present as melena, can present as hematemesis, intestinal perforation, peritonitis, meningitis, septic shock. So it's whenever assessing a patient who comes late in the disease course, it's always good to ask about melena, for instance, because that might be something the patient won't dismiss as something insignificant. Okay, now we move on to case definitions. So these are based on the NIH definitions, the NIH in Pakistan, and generally speaking, typhoid is a disease which is geography specific, because the resistance pattern is different, the socioeconomic factors are different in areas. So it's good to use local definitions and local recommendation. That's what the global bodies also recommend. Use the local antibiotic regimens that are tailored to the susceptibility pattern in your community. So case definitions: a suspected case in Pakistan would be considered a fever for at least 3 days, fever of 3 or more days with high-grade fever, basically 38 degrees Celsius with abdominal symptoms. So this would be someone you would, it's like a classic, something that you should start thinking about typhoid when this kind of patient comes to you. Okay, फीवर हो रहा है, 3 दिन हो गए हैं, बुखार, तेज़ बुखार है डॉक्टर साहब 3 दिन से हो रहा है, शायद abdominal pain है, शायद डायरिया है, ठीक है, प्लस माइनस, but this is the kind of the general category. Of course there's a large variation in patients, but this is the general kind of case that you should suspect कि यार इसको typhoid तो नहीं हो. Confirmed case would be someone who is lab confirmed by isolation of the organism from the blood, bone marrow, or stool or urine cultures. Now, unfortunately, in enteric fever, we don't have a very broad range of diagnostic tools available to us. The clinical history, some physical findings, blood cultures mainly, but there are not a lot of other reliable tools in our repertoire to diagnose this disease. Okay, so MDR would be resistant to these 3 antibiotics which were initially used against enteric fever, cotrimoxazole, amoxicillin, and chloramphenicol. And there is some interest in treating with these antibiotics now, but unfortunately there's not much research to back that up, because the idea is that generally as we move towards increased patterns of resistance to antibiotics, the older antibiotics that have now been abandoned start coming back into circulation, and there might be some better susceptibility to them now. But in Pakistan, as we saw, MDR resistance is quite common. XDR is resistance to these initial organisms, fluoroquinolones, and a 3rd generation cephalosporin such as ceftriaxone. Fortunately, right now, the vast majority of cases of XDR typhoid are reported in Sindh province. And in the Sindh province, the number 1 is Karachi, and then would be Hyderabad, and then the other smaller districts of Sindh. And that's important to keep in mind, because keeping the local context in mind, if you see a person who's come back from Karachi and now they're having symptoms, we should definitely think about XDR in them, as opposed to a person who comes from another province. Of course, this situation might change in the future, but as of now, this holds true. So the diagnosis, WHO recommends to use blood culture in all cases where we are suspecting enteric fever. The reason for that is that blood culture has 100% specificity, so it won't give you a false positive, right? Cultures in general don't give you a false positive unless there's contamination or things like that, but there's some reliability there. Sensitivity of a blood culture is maximum during the incubation period, so when the patient is not symptomatic yet, or during the first week. So that's when we expect, and that also, as you can see, is not a very high number. It's 50 to 70% sensitivity that we expect, but at least the specificity is 100%. So if you might not rule it out by a negative blood culture, but if you get a positive culture, you can definitely rule it in. And the disadvantage is that it might not be widely available and takes at least 48 hours for the culture results to be back. So in the absence of that, presumed diagnosis is generally, as we all see in the community as well, we practice this a lot. Presumed diagnosis and empiric therapy is what most patients, the care that most patients get. There's a problem with that the clinical diagnosis, like based on the symptoms alone, if we diagnose a patient, that has a very low positive predictive value. So it's even in areas that have a high burden, like Pakistan, there's a high burden of enteric fever. But still, if we can't reliably, predict that this person is going to have this disease just on the basis of their clinical symptoms. Antibiotic resistance is another problem that comes with this approach. It leads to overprescription in cases where we might suspect, but there's no, we're not confirming the diagnosis, and contributes to the emergence of strains such as the XDR strain. So in a way, it's a necessary evil, but we'll look at some ways we can temper it. So always send blood cultures if it's available. I think this is something that would be a take-home message. If blood culture is available, it should always be sent, because it can prevent these problems that come with empiric therapy. There are other labs as well that can help us. So the CBC, the expected picture in the CBC is an anemia, a normocytic, normochromic kind of anemia that we expect. WBCs are usually normal, or there's a mild leukopenia. That is what is expected. If you see a leukocytosis there, especially with the left shift with neutrophilia, that should alert you to the possibility of intestinal perforation, especially if it's late in the disease course, or the possibility of an alternative diagnosis or a coexisting diagnosis. CRP is something that's usually elevated, and also we have to think about other causes of fever when we are evaluating a patient who fits a a typhoid compatible picture. Cases, disease such as dengue, okay, disease such as malaria, I'm sure is quite uncommon in this part of Pakistan, in the northern Pakistan areas, I've been told. But if we suspect other typhoid, we should first also look at excluding other causes as supporting supporting evidence for our diagnosis. So serological tests, these are very popular, and the reason is clear because they're convenient, they're cheap, and they're easily available. But the problem with them is that they correlate very poorly with blood culture. So studies that have been done on the efficacy of these tests to diagnose enteric fever have given a very wide variety of results. So if we see at the Western studies or the company-sponsored studies, they show estimates ranging from 50% to 90%. But if we look at the local data, and again, as I mentioned earlier, typhoid is something where we want to really look at the local data because there is a lot of variability. So the local data suggests that these tests have a very poor correlation with blood culture. So if a person is positive on blood culture, 20% of the time you will pick them up on a Vidal test or a rapid antigen test, a typhoid dot test. So that's not really a very good benchmark to trust that test, right? So sensitivity and specificity both are quite low. And another problem is cross-reactivity with multiple diseases. So the test might be positive if a person has other illnesses as well, right? So WHO recommends against their use, but still they're widely practiced, and even the government of Pakistan has issued a notification, the NIH had issued a notification in 2019, strongly discouraging and in words just banning it. Okay, do not use this. Those were the words in that notification. Do not use typhoid or Vidal test for the diagnosis of typhoid fever. So that's the local guidance. All right, so patients with systemic toxicity in terms of management, systemic toxicity, we should obviously admit them, and if there's a suspicion for perforation, those should obviously be referred for emergency exploration. Most patients can be managed as outpatients, that's the good news. Adequate hydration, diet, and symptomatic treatment of fever and pain along with antibiotics. Now, antibiotics are the main treatment of this disease. There's no other option. The regimen should be guided by local patterns of resistance. So this recommendation, antibiotic recommendation that I'm sharing is based on the AKU antimicrobial guidelines, which are based on the local susceptibility patterns and the results of their cultures sensitivity that they do at their lab of typhoid fever. So ceftriaxone or cefixime for uncomplicated cases, 400 milligrams Q12 RD. This is in adults. And azithromycin if XDR is suspected or confirmed. All right. So if it's complicated, that would be ceftriaxone and 2 gram once a day plus IV azithromycin. So that's the regimen that they prescribe for complicated cases. IV meropenem, if XDR is suspected or confirmed, we move to IV meropenem, not just azithromycin. In that case, we move on to meropenem. Dexamethasone has a role in mortality benefit in cases that have altered consciousness. These are very late cases, patients who present with shock, have altered consciousness or present with coma. So these patients, the evidence strongly suggests that dexamethasone has a mortality benefit. So these are the only subset of patients who would be given dexamethasone. Other patients do not require dexamethasone in this disease. So there's the initial 60 mg loading dose, and then 10 mg every 6 hours for 48 hours, so 8 doses in total. Blood cultures, even if we're starting antibiotics immediately, we should send blood cultures and then adjust the results after the cultures are back. Another thing here is sometimes the patient is already taking antibiotics. In that case, should we send blood cultures or not? That's a common dilemma in the clinical scenario. So it's better to send the blood cultures, because if the patient is still spiking a fever, likely that antibiotic is not having any effect on their infection. So it's good to send the blood culture regardless if the patient is still spiking a fever. And on another point on blood cultures, so it's also been seen in studies that blood culture volume, the volume of blood that we send for blood culture, that has a correlation with the diagnostic accuracy of that test, the sensitivity of the test. So at least 10 to 20 ml of blood should be sent whenever we're sending a blood culture. No less than that is acceptable in terms of sending a blood culture. So we expect a fever to be gone in 5 to 10 days if the antibiotic is having an effect, and this is a little different from other diseases, because generally in other infectious diseases, if we expect that the antibiotic is working, we keep a window of 48 hours. So 48 hours, we tell the patients also, okay, 2 दिन लगेंगे कम से कम बुखार खत्म होने में, generally in other diseases. But in enteric fever, that duration is longer. Although the patient starts feeling better, they still keep having a fever for about 5 days, generally speaking. So we should counsel the patients accordingly कि जी 5 दिन लगेंगे बुखार बेहतर होने में. अगर 5 दिन के बाद भी बुखार बेहतर नहीं हो, फिर आप आके दिखाइएगा. So basically that means that the antibiotic is not having an effect. And also in a way that's another, evidence for against typhoid. अगर आप पेशेंट को एंटीबायोटिक टाइफाइड सोचते हैं, एम्पेरिकली आप उनको एंटीबायोटिक स्टार्ट कराते हैं, but the patient's fever immediately goes away with that antibiotic, then that suggests that probably शायद उसको टाइफाइड नहीं था, क्योंकि टाइफाइड का फीवर इतनी जल्दी जाता नहीं है. ठीक है. Okay, so antibiotics should be continued for about 7 to 14 days in total, or 5 days after fever is gone. So patient का fever खत्म होने के बाद कम से कम 5 दिन हम उसको antibiotic चलाएंगे. So that's the rule here. If in general आप prescribe करें तो 7 to 14 days is what we suggest. So once the patient has stabilized clinically, IV antibiotics can be switched to oral. IV ceftriaxone पे थे तो oral cefixime पे switch कर देंगे हम. And relapse is something to look out for in about 2 to 3 weeks. Around 5% of patients can become chronic carriers, and that means they keep excreting the organism in their stool for after 1 year after the infection. So within 1 year there can be some excretion in the stool, but after 1 year if that persists, then that person would be labeled a chronic carrier. And as you know, chronic carriers might have a focus in the gallbladder, and to treat that might have to remove the gallbladder. Cholecystectomy might be done. And routine stool culture is not recommended for carrier status. मतलब हर patient का हमको stool culture नहीं करना है. Only people who are food handlers, for them the recommendation is that get their stool cultures done, because as you know, the case of enteric fever that was spread via a person who was a food handler in New York City, a lot of people got infected because of that. I forget the name, it was something Mary. Typhoid Mary, exactly. So Typhoid Mary has given us this finding. So that's why we recommend for people who are food handlers to get their stool cultures annually, just as an employee fitness kind of thing. So prevention is the key, because no matter what we do, if there is a lot of risk factors in the community, we will not be able to treat every case. And as you can see, the mortality burden of this disease is quite high. And prevention is the area where the key to this disease is, in my opinion. So sanitation, hand hygiene. So whenever we have a patient who comes with enteric fever, at least for that one patient, we can pass the message to them and from them to the rest of their contacts that हाथ धोना कितना important है, food handling, how should be, like salads अगर आप धो रहे हैं तो फिर आम पानी से धोएं, लेकिन खाने को अगर आप रॉ खा रहे हैं तो उसके लिए अलग से पानी रखें, जो कि आपका ट्रीटेड पानी जिससे आप उसको वॉश करते हैं. Cook foods appropriately, boiling the water before drinking it. So all those guidances are helpful in preventing this from happening again. ठीक है जी. So vaccination is something that is new in this aspect, that in 2019 WHO recommended the typhoid conjugate vaccine for 6 month to 15-year-old children. But in 2019, the EPI has formally incorporated that into the Pakistan's expanded program of immunization. So the TCV type bar vaccine, a single intramuscular dose at 9 months, जब measles का dose लगता है उसके साथ एक typhoid का भी dose लगता है. So this has been inducted into the EPI, and this provides protection for at least more than 2 years. But because this is a recent vaccine, so studies are ongoing about if a booster is needed or not. But generally, this is something that's been added to the routine vaccination schedule of Pakistan. So that's it from my end. If there are any questions, more than happy to answer.
Well, Imran, it was a good presentation. Thank you. Secondly, I have a question like, is there any terminology run like recurrent typhoid? Like fever, hota hai, eco typhoid is settled down in patient having same symptoms again?
Yes, that can happen.
Yes. For recurrent typhoid, is there any treatment other than these azithromycin and such?
Very good. So recurrence can occur in about 3 to 6 weeks. That can happen, but the treatment is the same as the initial. तो जिस एंटीबायोटिक से पहले उनको इफेक्ट आया था वही आपने देना, अगर आपके पास ससेप्टिबिलिटी है. अगर नहीं था, फॉर एग्जांपल अगर आपने पहले सेफिक्सीम से ट्रीट किया था, देन मूव ऑन टू एजिथ्रोमाइसिन. बट जनरली इफ द पेशेंट वाज ससेप्टिबल, अगर कल्चर में आपको मिल गया कि ससेप्टिबल है पेशेंट उस एंटीबायोटिक से, तो ट्रीट विद अनदर कोर्स of the same antibiotic, because sometimes it happens that the patient might not be taking the doses properly. That can be a cause of it. Yeah, it sometimes can happen that the patient might not continue it for long enough. So making sure to ensure those compliances, give another course. We generally give another course of the same antibiotic, or if we suspect that this was maybe a strain that's not covered by the initial, then we go for another antibiotic.
Well, what I've heard, might be Dr. Imran will elaborate, like for recurrent typhoid, people end up in a polycystic carrier typhoid.
Very good. So carrier is different from recurrence.
Nowadays it's not recommended to do cholecystectomy for carriers. We can treat.
Very good, sir. So for carriers, there is a longer course of antibiotics, but that's an extreme. For example, some people might have cholecystitis along with it or something like that. Or if we're treating with a longer course of antibiotics and still not getting the desired effect, down the line it could be a possibility, but of course not as a first option, of course not.
They are chronic asymptomatic carriers. Basically, the organ settles in the gallbladder. Initially, it was routine practice to do cholecystectomy. It's not routine practice now.
Very good. So he's right. That's not recommended.
What asymptomatic carrier are more dangerous than symptomatic?
Do you suggest, what antibiotic do you suggest for chronic carriers?
So ciprofloxacin is suggested for chronic carriers. Suggested for at least 12 weeks, sir.
Is there any role of ampicillin nowadays in chronic carriers?
So those initial medicines, ampicillin, amoxicillin, cotrimoxazole, those are also good for chronic carriers. They're given,
This was
yes.
the drug of choice, secondary to chloramphenicol. Chloramphenicol, there were a lot of chances of carrier cases, and we used to give ampicillin along with probenecid in highest doses.
Okay, sir.
Up to 3 grams, 6 of them.
Okay.
Is there any role of ampicillin nowadays?
Ampicillin, I'm not aware of, sir. Amoxicillin, yes, it is given as. Amoxicillin is given for this purpose. So the antibiotics that are given for the treatment of carriage are different from those that are given for acute typhoid. Yes, you're right.
Is there any clinical importance regarding this treatment between the salmonella typhi or paratyphi?
Sir, clinically it's indistinguishable. Generally, as paratyphi gives a more milder disease. Milder disease.
Less common.
Yeah. But in general, in terms of treatment, it's the same thing. We have to give the same antibiotics in general.
Dr. Imran, my question is that you mentioned among the complications there is a shock as well.
Yes, sir.
In complication phase and third week, patient might have went into the shock.
Yes, sir.
Is there any other cause other than enteric perforation of shock? Usually, complication is enteric perforation.
Yes, sir.
If there is no enteric perforation, and even patient can get shock.
So if septicemia develops, yes, then the patient can go into shock because of that.
How
Yes,
many, is there any number of cases regarding this one? Without perforation, patient goes to shock.
Generally, sir, in our community, people overtreat with antibiotics, if anything. So most people do not get to that stage. Even if they're partially susceptible to that antibiotic, they don't get into complications that much. They might go into chronic carriage, yes, as you're saying, sir. In children, yes, there is a larger percentage who might go into complications because it's difficult to recognize in them as well. But I'm not, to the specific questions, I'm not aware of what the breakup is between septic and perforation causing shock. Yeah. But dexamethasone is something that is recommended for patients who come in that, because it has mortality benefit in that regard.
Here in GB, many physicians advise Typhoid because of the
Yes, sir.
test, what is the sensitivity and specificity?
So the sensitivity is very low. It's in the 20s. The specificity at best is around 60%. But as I said, there's a lot of variability in those estimates. So the local data, it shows that the sensitivity is very low. So for ruling out typhoid is not a good way. And for diagnosing it also, it's quite, so it ranges from 20 to 60%.
Actually, blood cultures are not available in areas like GB.
So even in the provincial headquarters,
So how can we diagnose if we cannot diagnose the help of this?
so I think avoiding typhoid and tests such as that is important, because that gives a false sense of certainty. For example, a false positive person, you might be giving them IV antibiotics. Okay? If the most important is the clinical picture, in the absence of a very good test, in the absence of reliable blood cultures, and this is a problem faced all across the world, because even blood cultures are not perfect, right? So 50% sensitivity or 70% sensitivity is not that great, right? So the clinical picture is important, because as a general rule, typhoid does not present without a good, proper fever. Like किसी को अगर feverish feel हो रहा है and 99 पे वो चल रहे हैं, 2 हफ्ते हो गए 99 का fever चल रहा है, that is probably not typhoid, right? So that's one thing to keep in mind.
Spleen is also important. Spleen.
Yes, hepatosplenomegaly. So clinical examination, the behavior of the fever itself, and supporting tests like the CBC अगर आप देख लेते हैं, उसके अंदर अगर आपको for example डेंगू की तरफ पिक्चर मिल रही है, या आपको कोई वायरल पिक्चर मिल रही है, या बैक्टीरियल मिल रही है, so then that points away. So it is tricky. I understand your point, but one question I also do have: blood cultures. How available are blood cultures in Gilgit city?
Blood culture is available only outside labs or government hospitals are not available.
Okay, sir.
Till now.
And how good are those labs? How reliable are the results of those labs in your experience?
इसमें एक चीज़ मैं आपसे डिस्कस
Sir.
करूँ। देखिए अभी ब्लड कल्चर का डॉक्टर एजाज ने यहाँ डिस्कस किया कि
जी, जी,
बड़ा
सर।
कमरसम है और मेरा ख्याल इतना रिलायबल भी नहीं है, जैसा आपने कहा कि 15 ml
जी। Bottles होते हैं, बिल्कुल सर।
वो हमारे पास नहीं है, पता नहीं कैसे ब्लड कल्चर होता है, एंटीबायोटिक ऑलरेडी ले रहा होता है। हमने ये सुना कि अगर आपने एंटीबायोटिक लेते हो पेशेंट का कल्चर कराना है तो आप 24-48 स्टॉप करें एंटीबायोटिक को, फिर कल्चर करें उसका, चलो इसको छोड़ देते हैं। हमारे सेटअप में हम क्या हेल्प कर सकते हैं, जैसे कि CBC की आपने बात की,
जी सर।
लिकोपीन है, थोड़ा सा लिम्फोसाइट,
बिल्कुल सर।
उसके साथ जो क्लिनिकल प्रेजेंटेशन है जैसे रिलेटिव ब्रेडिकार्डिया होगा, या फिर आपने अभी बात की वो रोज स्पॉट्स की
जी
बात
सर,
की, वो
बिल्कुल।
मॉर्निंग था, लेकिन वो 7th डे में आपको मिलेंगे
25%.
लोअर चेस्ट में
बिल्कुल
बड़ा पैथोमोनिक है, और वो उसको रेजिडेंट रेंज भी कहा जाता है, क्योंकि वो 2 to 3 डेज से ज़्यादा नहीं करता,
सही है।
इसलिए मेरा ख्याल इतना हेल्पफुल वो नहीं होगा, लेकिन अगर वो मिल जाए तो पैथोमोनिक है, तो उसमें से भी आप कल्चर ले सकते हैं।
बिल्कुल
उससे
सर,
कहते हैं कि बड़ा अच्छा यील्ड है उसका,
उसमें से
मुझे
भी
याद नहीं है,
रोज स्पॉट में से बिल्कुल ले सकते हैं सर। यस,
इस पर थोड़ा सा आप बताएंगे हम, ये हमें मेरा ख्याल है हमारे सेटअप में ये चीज़ें हेल्प कर सकती हैं।
बिल्कुल सर। तो जो क्लिनिकल,
और क्लिनिकल प्रेजेंटेशन को आपको
तो CBC जो आपका है उसके अंदर आपको नॉर्मल या थोड़ा सा लिकोपेनिया मिलेगा उसके अंदर, ठीक है। और न्यूट्रोफिलिया आप इन द एब्सेंस ऑफ कॉम्प्लिकेशन न्यूट्रोफिलिया एक्सपेक्ट नहीं करते हैं। अगर आपको क्लिनिकल पिक्चर कॉम्प्लिकेशन से कंपैटिबल मिल रही है, जैसे पेशेंट को बहुत सिवियर टेंडरनेस हो रही है, ठीक है, या आपको लग रहा है कि परफोरेशन है या थोड़ा लेट आया पेशेंट, तो उसमें आप इस जनरली CBC आपको एक लिकोपेनिया या नॉर्मल काउंट्स देगा, थोड़ा सा एक नॉर्मोक्रोमिक नॉर्मोस्टेटिक एनीमिया देगा। उसके अलावा आप रिलेटिव ब्रैडिकार्डिया एक फाइंडिंग है जिसको देखते हैं, एंड इट्स अ कॉम्बिनेशन ऑफ दिस थिंग्स, एंड देयर इज़ नो सच डेटा कि जी इन सबको कंबाइन करके उसकी क्या सेंसिटिविटी स्पेसिफिसिटी है। लेकिन इतना ज़रूर है कि क्लिनिकल पिक्चर अलोन पे रिलाई करना भी इज़ नॉट रिलायबल, बिकॉज उसकी प्रेडिक्टिव वैल्यू भी लेस देन 50% है, ठीक है। सो इट्स अ कॉम्बिनेशन ऑफ दीज टूल्स, दिस इम्परफेक्ट टूल्स दैट वी हैव, ठीक है, दैट वी गिव, एंड एम्पेरिकली जो एंटीबायोटिक हम दे रहे होते हैं, ठीक है, उसके अंदर अगर हम ये कंसिडरेशन रख लें कि फॉर एग्जांपल इस पेशेंट का रिस्क प्रोफाइल XDR टाइफॉइड वाला है या नहीं है, सो दैट आल्सो माइट हेल्प, बिकॉज इट्स अ डबल एज स्वॉर्ड ना, कि हम एंटीबायोटिक से ट्रीट करना भी है हमें और ओवर ट्रीट भी नहीं करना है, क्योंकि ओवर ट्रीट करें तो XDR की तरफ चीज़ें जा रही हैं। और जैसे अभी आजकल कोविड के अंदर वैसे एजिथ्रोमाइसिन बहुत प्रिस्क्राइब हुआ है, तो दैट्स अनदर बर्डन ऑन दैट एंटीबायोटिक के, उसकी रेजिस्टेंस जो है इंक्रीज़ होने का चांस है, बिकॉज एजिथ्रोमाइसिन इज़ द ओनली